Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we explore rapid syndromic testing for gastrointestinal and joint infections. To follow along with the slides, visit the show notes for this episode. Now let's get started as our faculty introduces some case studies.
I'm Trevor Van Schooneveld, an infectious disease physician at the University of Nebraska Medical Center and the director for our Antimicrobial Stewardship program. We're going to start with gastrointestinal infection syndromic testing. I always like to start with a case. This 36-year-old who presented with 4 days of diarrhea described the diarrhea as watery, 5 to 7 stools per day, but the day of presentation said there was some blood present in the stool. Reported fevers up to 101 the past couple of days and some crampy abdominal pain. On exam, didn't have any guarding, but did have some tenderness. This person lived in rural Nebraska with a spouse and 3 kids, had an interesting history of caring for multiple animals, including chickens, turkeys, and goats, and a child who had a pet turtle. There's 2 questions to consider here. Should you test this person to determine the etiology of their diarrhea? It's an important question because diarrhea is a common problem, and not everyone who has diarrhea do we need to sort the etiology out. But there are certain patients where we should. And if you are going to test this patient, what test or tests would be most appropriate to utilize? The Infectious Disease Society of America actually has guidance on who should get tested for infectious diarrhea or gastroenteritis and who doesn't. They recommend thinking about the patient's immune status, their age, potential exposures, and travel when thinking about testing. And they specifically recommend testing when patients have fever, bloody or mucoid diarrhea, severe abdominal pain, diarrhea with signs of sepsis, or are severely immunocompromised, such as a solid organ transplant patient. They also recommend in travelers not to test for the etiology of diarrhea unless it doesn't resolve by 14 days or it's severe. And my general definition for severe is bad enough to put you in the hospital, would definitely be a severe diarrhea. And so those are the criteria for people who should get tested. And if you think about our patient, she met 2 of those criteria. She had both fever and bloody diarrhea. What tests do we have to determine etiology of infectious diarrhea? Well, we have a stool white count or lactoferrin. That doesn't tell you the etiology, but it does point you in a direction if it's positive versus negative and there's inflammation or none. There are bacterial tests such as stool culture, Shiga toxin assay, C. difficile testing. We can test for viruses using virus-specific PCRs or rotavirus antigen for our young children. There's also parasitic testing with stool oven parasites. Some centers, if you order a stool oven parasite, will give it Giardia and Cryptosporidium antigen only. But there are also traditional stool ONP testing with the trichrome and AFB stains. But many centers have moved to molecular panels. There are 6 GI panels currently available, and they contain a variety of different pathogens. Some contain many, some contain fewer, some detect bacteria, viruses, and parasites, and some detect only bacteria and viruses. The turnaround time of these panels is relatively short, typically less than 2 hours, but definitely less than 4 to 5 hours, so much faster than traditional culture. They're also more sensitive than traditional culture, but they only detect what they're designed to detect. And so if you have a patient with diarrhea and you're using a molecular panel, it's very important you understand what's in that panel and what isn't in that panel. And so, for example, using the Veregene panel and you're worried about parasites, that's not the kind of test we would use. You'd want to use more traditional testing and not expect the panel to detect a parasite. There are many advantages to these multiplex GI panels, and there are reasons labs have switched over to them. One of them is a rapid turnaround time, which I already highlighted. Another is that they're much easier actually for a micro lab to perform. There are multiple tests basically built into a single test. Rather than running 4 or 5 assays, they can run a single assay to detect multiple pathogens. They also have greater sensitivity, which I'll highlight in a minute. They detect many pathogens using the single test, and this has resulted in improved treatment. This study, which was a prospective multi-center study comparing film array to conventional stool testing, highlighted this. In this study, they improved detection very significantly compared to conventional culture. That was increased detection of bacterial pathogens and an even greater increase in detection of viral and parasitic pathogens, primarily because clinicians hadn't ordered the tests for them. They also did that faster. Because of faster results, they were able to shorten time to antibiotic therapy, and the therapy that was given was more likely to be targeted. And so there are some real advantages to these panels. Now, if you use these panels, there are advantages, but there are also challenges you're going to encounter. A couple of the challenges are detection of pathogens in asymptomatic patients and multiple pathogen detections. This was a study done in Rwanda on children who had acute diarrhea or who had no history of diarrhea. And I understand this is not our typical US population, but I think it's illustrative of the issues we can encounter here. What you'll note is in children who had diarrhea, more than half of them had at least two pathogens, and some had three, four, five, or even six pathogens. And so when you have multiple detections, you'll have to sort through what is most likely based on the clinical presentation and how do I manage it. The other thing you'll note is that the healthy controls, 80% of them had a pathogen detected. And so this is a good reason not to run these tests on patients who don't have diarrhea. Then we don't have to worry about it. Most patients, if they don't have diarrhea, figuring out what's in their stool isn't going to make any difference. This multiple pathogen detection is more of a problem in children, in travelers, and also in our immunocompromised patients. Another issue to consider is the challenge of C. difficile testing. Some of these panels have C. difficile tests on them, others don't. And so if your panel has C. difficile testing, it's a molecular means of testing. The problem with molecular testing for C. difficile is it alone does not differentiate a meaningful patient population. The study I've cited here showed that patients who had a positive PCR test for C. difficile but were toxin negative had identical outcomes to people who tested completely negative for C. difficile. And so the guidelines recommend coupling molecular testing with a more specific test. And so your lab will have to figure out, how do we do that? Traditionally, that's a toxin assay. If we're not doing that, we're going to have overdetection, and that's going to result in overtreatment. In this study that looked at over 400 patients who had C. difficile detected by film array, only 22% were positive by a toxin assay. So only 1 in 5 actually had toxigenic C. difficile. But treatment was given to 2/3 of those who didn't have a toxin detected in their stool. And so you'll have to sort through this issue as well. Finally, there are the E. coli pathotypes. Some of these E. coli pathotypes, we don't have a lot of data what to do. Shiga toxin producing E. coli and invasive E. coli, those are pretty straightforward. It's the enteroaggregative, enteropathogenic, and enterotoxigenic E. coli, which are more challenging to interpret. This is a study done in children at 2 pediatric hospitals. And what they found is half of children tested had one of these E. coli pathotypes detected. About 20% of them are treated. And when clinicians look back, about half of that was considered totally unnecessary and not needed. Many of these E. coli pathotypes, particularly the EAECs, EPECs, ETECs, they don't need treatment. And what we recommend is mostly to ignore these unless it's the only pathogen detected. They have very significant diarrhea. They're not improving over time, and we don't have any other explanation. And then you could consider treating, but I think it's still a little unclear whether that will provide benefit or not. So in our case, our patient tested positive for Campylobacter. Not surprising. She had fever. She had a pretty classic presentation. She had exposure to poultry, which is a risk factor. Many patients with Campylobacter improved. This is our guidance on what to do with Campylobacter, but patients with high fever or bloody diarrhea, it is recommended to treat them. And the preferred therapy is azithromycin for 3 doses. That's preferred over fluoroquinolones, which are active, although less active than macrolides. It might give longer in immunocompromised patients. So our patient was treated with 3 days of azithromycin and had resolution of her symptoms. So some key takeaways: not everyone with diarrhea needs diagnostic testing, but some do. Those with fever, severe diarrhea, bloody diarrhea, immunocompromised, signs of sepsis, those patients do need testing to determine the etiology of their diarrhea. The GI panels are more sensitive than traditional testing, and they provide results more rapidly, allowing us to target our therapy better. But there are challenges we'll encounter, like multiple detections, C. difficile infection, and E. coli pathotypes, which we'll have to sort through. Next, I'd like to move to joint infection syndromic testing, which is a little bit of a different animal. We'll start with another case. 50-year-old with acute monoarthritis presented to the ED complaining of severe right knee pain. It developed over the last 24 hours. This patient had a history of gout, but wasn't on any treatment. In the past, gout had affected the toes and once in the wrist, but never in the knee. Had a low-grade fever and was tachycardic, pretty uncomfortable, but blood pressure was normal. Right knee had an obvious effusion, very tender, decreased active and passive range of motion. A knee arthrocentesis was performed. White count was 54,000. It was definitely PMN predominant, and a gram stain was negative. So that raises a question. What is the most likely cause of this acute monoarthritis? And the differential for this, I think the top two things are going to be infection or crystalline disease. You could think about some of these other things, but they're much less likely in this patient presentation. The problem we have is, how do we sort that out? Synovial white cell counts are generally over 50,000 when there's an infection, but in one study, only 15 to 30% had a white count under 50,000 who had an infection. We definitely see crystalline arthropathies with white counts over 50,000. And in another study, sensitivity of synovial white cell count of over 50,000 was only 56% for infection. Gram stain sensitivity is even lower. And the other problem is, we sometimes see crystals in an infection. Because they already have crystals there, they're just not causing the problem. And so this makes it very challenging to manage. So how should we manage this patient? Should we treat them for crystal arthropathy with steroids? Should we treat for infection with antibiotics and potentially joint washout? Should we treat them as all? What Up to Date recommends, and they're a guidance resource, they recommend if a patient has a history of crystalline arthropathy, you should manage it as such. But if there's no history of crystal disease, presume infection until proven otherwise. Rapid diagnostic tools certainly would be helpful here, though. And we do have some joint panels. In the US, there's one FDA-cleared joint panel from BioFire. There are some other panels that are available that are not FDA approved, but are being used. And in Europe, there are also some other panels. I'm going to mention the BioFire joint panel because it's only one approved currently in the US. If you've ever seen these panels, it has some of the same organisms you'd anticipate, such as Staph aureus, Streptococci, common gram-negatives, and Enterococcus. It has some more unusual pathogens, though. It has a number of anaerobic pathogens, including Peptostreptococcus, Parvomonas, and Kingella kingae, which is an important pathogen causing septic arthritis. It also has a couple of yeasts and some resistance genes. And this panel is more sensitive than traditional culture. It ran about 90% in the validation study that was performed. Sensitive, it was 99% specific. So if a pathogen was detected, it was definitely there. Some of the pathogens it misses, I think, are important to mention. What you'll note here is, on the panel, there are no coagulase negative staph, no Staph epidermidis, no Corynebacterium, no Cutibacterium acnes. And so those pathogens are not included in this panel. And so it doesn't detect all of the pathogens that cause acute septic arthritis. Our patient was positive for Staph aureus, which was MECA negative. It also, the next day, grew from the synovial fluid cultures and the blood cultures. Based on our guidance, our patient was started on sulfasalin and actually went to the OR the same day for joint washout based on the panel results. And so very rapidly was managed in an appropriate way. There's less data on these panels as they're relatively new, and I thought I'd just highlight a couple of studies that I think are helpful. This is a study done in France, over 300 synovial fluids, done for acute arthritis. Just over half are native joint, and they compared it to a 14-day held culture. The panel was positive in about half of patients, And there were no false positives. Not everything was confirmed by culture, but those that weren't positive by culture were positive by molecular methods. There were 155 negative panels, and 83% of those were culture negative, meaning there were what we would call 27 false negatives where the panel missed that there was an infection. Now, did it really miss? It didn't in the majority of these, because 2/3 of them were off-panel organisms, such as Staph epidermidis, Staph capitis, Corynebacterium, or unusual gram-negative rods. And so that is something that's important to understand about this panel. It's quite sensitive, but it's not perfect, and it only detects what it's designed to detect. It won't detect off-panel organisms. And so it doesn't rule out infection, but it certainly can rapidly rule in an infection. What about prosthetic joints? Prosthetic joints are a little bit of a different animal when it comes to infection. You can find different pathogens based on the timing of the infection, whether it's early after surgery or late, and also based on acuity of infection. The organisms causing acute prosthetic joint infection are often different than the organisms causing chronic infection. In one study that evaluated the joint panel in early acute and late acute, so these are all acute prosthetic joint infections, they found poor sensitivity for early acute PJI. And that's mostly because they missed off-panel organisms. Coagulase negative staph, Staph epidermidis, Cutibacterium, gram-positive rods, but good sensitivity for late acute prosthetic joint infections. And that's because these were primarily hematogenic seeding, things like Staph aureus, Streptococci, occasionally gram-negatives. And so I think this has potential greater utility in late acute infection, where hematogenic seeding is often the route, but could be used in acute and chronic PJI. This is a technology where we're figuring out how to best use it and where it best fits. And I think, as I mentioned, if positive, it's very useful. It's going to rapidly allow us to triage patients who say need to go to the OR or need to get a joint washout. It's going to identify some of those more challenging to detect pathogens, particularly the anaerobes. Um, but for other pathogens we worry about, like the skin flora, it's not going to detect those. And so it won't replace traditional culture, but it will help us to supplement. And I think, um, time is cartilage. Time is joint function, is what we say in septic arthritis. And so having people sit around for a couple of days while we sort out whether they have an infection is not ideal. And so the faster we can figure out they do have an infection, intervene with appropriate antibiotics and surgical therapy, joint washout, things like that, the hopefully better outcome we will have. And I think that is the potential for doing that more rapidly. And the other thing I'll just say is who uses joint panels? It's usually not going to be infectious disease physicians. It's going to be rheumatologists, orthopedists, hospitalists, ED physicians, who are the people who are evaluating these patients when they come into clinic, when they come into the ED. They're the ones doing the joint taps. And so they're the ones who really are going to have to understand, I should do a panel in this patient where I'm worried about a septic arthritis to help sort out if they have an infection along with my other testing. And so that's the group of providers that really needs to have an understanding of these panels. And you always feel silly when you've done a joint aspirate and injected steroids, and then 2 days later it grows a pathogen. And so the hope would be we could work around that and have less of that. Maybe not that. So some key takeaways in the joint syndromic panel. It does increase detection of organisms over traditional culture. It provides results faster than traditional culture in hours rather than days. It's sensitive, but it's not perfect. And it only detects what it's designed to detect. And so it won't detect every pathogen that could conceivably cause an infection. And where do we think it's useful? This is my own opinion. I think in acute monoarticular arthritis, particularly of native joints, this is a very reasonable test to use as you're doing your evaluation of synovial fluid and for crystals. In prosthetic joint infection, I think you have to put it into clinical context and in consultation with experts decide Is this something that's useful? Again, if it's positive, I think it's quite useful. If it's negative, it doesn't necessarily rule out infection. Thank you for your time. I appreciate it.
Yes, and thank you. To learn more about rapid diagnostic testing and other infections such as blood infections and respiratory infections, click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.